Hello, everyone. So Sarah Gillespie from the Urban Institute. So a recap on some of the work I've done around housing and healthcare. It really, I've been doing research on permanent supportive housing for a long time, and I think the work on healthcare really grew with the Denver Supportive Housing Social Impact Bond, or we call it Denver SIB. That was a randomized controlled trial evaluation, and it was really focused on criminal justice outcomes, but we were able to take a look at 2 years of healthcare outcomes and really saw pretty significant impacts. And so I think the SIB was the one of the first times we saw in that RCT framework prove out the theory of impact around housing and healthcare. So we saw that shift that you want to see. We saw a decrease in emergency ED visits. We saw an increase in outpatient preventative care, an increase in prescription medications. And it was just a really nice example of that theory of impact that when you have the access to the right housing and the right services, you can shift that healthcare utilization and get the services folks need. And so because that looked so promising, that led to the creation of a new program we call a new evaluation called the Housing to Health Program, and another 7-year randomized control trial, which is really entirely focused on those healthcare outcomes, and particularly the hypothesis that over a long enough time period, that shift from expensive emergency services to less expensive community-based preventative healthcare could have a net reduction in healthcare expenditures. And that's really what we're testing is, can we find an impact on those net healthcare expenses? And I think the study is long enough and large enough that we might be able to dig into questions like, how long does it take to find a reduction in expenses? And, are there different patterns in utilization for different types of diagnoses or healthcare needs? I think that's really a lot of the questions that we're hoping we can dig into. And so around the same time when ARPA dollars became available, Colorado decided to kind of expand the model that the SIB had proven out and expand statewide and really put a ton of resources into expanding permanent supportive housing across the state. And we had a connected evaluation to that effort that was a quasi-experimental look over a couple years at what happens when you try to take this model statewide and really try to make a case for Medicaid to invest in the expansion of PSH. And what that study found is that we were able to look at 1-year outcomes. And just in that first year, we started to see that same theory of impact. We saw that residents who got connected to PSH increase their access to the types of healthcare services we would want folks to get, increased access to primary care, to outpatient care, and prescription medications. We were only able to look at 1 year, so I think there's still a little bit of a story that maybe wasn't told there. We didn't see that same decrease in the emergency services at just 1 year, but I think there was a lot to say about how PSH provides that platform and connection to healthcare services. The other interesting thing about that study is there was a large implementation component that looked at what does it take to create a healthcare benefit, a Medicaid benefit that PSH providers can actually use, and that providers who are not used to being Medicaid billers can take advantage of and use to expand their ability to provide housing and services. So that was that study. And finally, the last thing I'll mention is that this work on the Housing to Health Initiative in Denver is leading us into a body of work we're calling high acuity homelessness, or what works for people with the most complex healthcare needs. This is a small share of people. Most people would not fit in this category, but there are a small share of people who have very complex, particularly behavioral healthcare needs. And this work is really leading us into questions around how are these needs changing over time? How does the drug supply impact these healthcare needs? How do these residents define their own health and well-being goals? What did they say about what PSH provides in terms of recovery and treatment opportunity? And then what would it look like? We're testing new models like bringing contingency management, which is a program for that can be used for things like methamphetamine and stimulant use disorder? And what does it look like to bring a contingency management program into a Housing First PSH program? And how does that help meet the needs of residents? So that's kind of a summary of where we're headed with the research.